Сегодняшняя лекция посвящена тактике ведения пациентов немелкоклеточным раком легкого. Долгое время немелкоклеточный рак легкого оставался прерогативой хирургов, но в последнее время появилось очень много новых лекарственных препаратов, которые позволяют добиться длительной ремиссии пациентов и очень хороших результатов. Сегодня лекцию будет читать профессор Майкл Мартин. Он работает в Западном центре онкологии и научно-исследовательском институте Мемфиса, штат Теннесси, Америка. И он будет читать лекцию по теме «Тактика ведения пациентов немелкоклеточным раком легкого». Если у вас будут вопросы, вы можете задавать их в чате. К сожалению, у него недостаточно свободного времени, всего лишь 30-40 минут, поэтому мы постараемся обеспечить субтитры в наших последующих записях. Поэтому приносим свои извинения за то, что перевод не будет возможен сегодня. Okay, you can start your lecture.
Okay, so thank you very much, Alisher, for arranging this and for giving me the opportunity to speak to you guys this morning for 30 or 45 minutes or what have you. I'm going to be talking about non-small cell lung cancer and really looking to focus on how things have changed over the past 7 to 8 years with non-small cell lung cancer. Everything that we're going to be, I'm trying to advance my, okay. So everything we're going to be talking about is going to be metastatic non-small cell lung cancer or biopsy-proven stage 4 disease. The other caveat to it will be that we'll only really be talking about people who have what's called oligometastatic disease. So with non-small cell lung cancer, when you have oligometastatic disease, which means 3 or less sites of disease or metastases, you actually treat it much more aggressively than people who have multiple sites of disease. So for the purposes of this lecture, the assumptions for the data are really going to be, what we're talking about is going to be people who have more than 3 metastases and that the metastases have been biopsy proven by interventional radiology or some other modality to prove that indeed the person has disseminated cancer. Do you want to translate that, Alisher? Or
you can continue your presentation and we will provide subtitles. I mean,
okay.
After recording.
So the thing then that becomes very provocative question and probably first came up at a presentation at the American Society of Clinical Oncology, which is our big national meeting in America every June. And around 2015 is are you able to cure somebody who has metastatic stage 4 lung cancer? Again, with the caveats that I have laid out. There was a presentation where they used a combination of 2 immunotherapy drugs, ipilimumab and nivolumab. They were dosed in the fashion that they are used in melanoma. And in this presentation, they reported that the combination, when it's dosed like it is in melanoma, was way, way too toxic for anyone to really tolerate with metastatic lung cancer, because melanoma patients are typically younger, they're non-smokers, they don't have all the comorbidities. But when you were looking at metastatic non-small cell lung cancer patients with all of their comorbidities, the mortality rate from the combined immunotherapy on the melanoma schedule, which includes high-dose ipilimumab at 3 milligrams per kilogram, in combination with the nivolumab, you had around a 20 to 25% death rate from pneumonitis. But so the presentation was taken as an, we shouldn't do this way. But the one little pearl that was left in there was there were a group of people, 3 or 4 people out of the 50 people who were treated with that combination immunotherapy who actually went into a complete radiographic and pathologic response that was durable and lasted years. That was the actual very exciting slide that they put up after they said how many people actually died from the high dose therapy. But that was the first little nugget in 2014 and 2015 that you may actually be able to cure metastatic lung cancer. But in order to talk about immunotherapy and the current therapies, we have to establish the past. So if you're looking at survival rates for metastatic lung cancer, and this is a slide from 2004, but it makes the point that 5-year survival with metastatic lung cancer is less than 1% when you have only chemotherapy. So everything you're doing for people with multiple sites of metastatic disease is palliative, and almost no one lives over 5 years. And as you can see, at least in the United States, almost half of people will actually present with stage 4 disease. So in the era before immunotherapy and targeted therapy, you were telling people that they had on average 10 to 12 months to live, and almost no one would be here in 5 years. We're going to talk, and let me show you the data for that for chemotherapy, where I'm getting that from. But we're going to talk throughout the lecture about, can we change this stage 4, only 1% of people being alive, or not? So the background for chemotherapy, one thing to know about that is the chemotherapy clinical trials only really include people with an ECOG performance status of 0 or 1. That means that for people with metastatic non-small cell lung cancer who present, who are not able to be up and active over 50% of their time, are not eligible for chemotherapy. So the 50% of the time includes time in bed, but just because you got out of bed and walked over to recliner and sat there for another 45 minutes does not mean that you are now out of bed, if that makes sense. So it's being up and active over half the time. So people have to walk into clinic in the United States to get chemotherapy for non-small cell lung cancer. We won't actually give them chemotherapy in the hospital because it's futile. You have to be up and moving around. So this is the study for, by Judith Schiller that was presented in the New England Journal of Medicine in approximately 1999 or 2000. And this is really what gave us the backbone for chemotherapy for non-small cell lung cancer. In this study, they actually did take some people with performance status of 2. Again, those are people 50% of the time in bed or in the recliner, and randomized them to 4 different chemotherapy regimens. This is where the standard of care really was born in the United States, and most people use carboplatin and paclitaxel as their first-line chemotherapy regimen. This was a randomized study of 1,000 people that randomized people between 4 different arms. 3 of them were cisplatin containing, 1 was carboplatin containing. And it was asking, can we get away from cisplatin in stage 4 lung cancer? Also of note, these regimens were only given for 4 to 6 cycles and then stopped. There was no maintenance therapy. There was no continuation therapy. There was also no role for retreating someone with a platinum. So after you've given your 4 to 6 cycles, if someone progresses with non-small cell lung cancer, regardless of the time to when they progress, you have no data, which I won't go through, but there's negative trials for retreating with a platinum. That is different than small cell lung cancer, where you can retreat with a platinum based on the platinum-free interval. In non-small cell lung cancer, do not repeat your platinum-based therapy. But in an effort to mitigate side effects, this was a 1,000-patient randomized study of carboplatin versus cisplatin-containing regimens. One thing to note when you're looking at all patients is that people with a performance status of 2, down here at the bottom, only had a 14% response rate and had a survival of 3.9 months. And they only benefited from the chemotherapy for 1.5 months. This is really showing that when someone is already sick enough to spend 50% of their time recumbent, i.e. either in bed or a recliner, they are not a candidate for chemo. It will not significantly benefit them. Versus if you look at people with a performance status of 0, so people who are able to move around, walk, and still perform their own activities of daily living and take care of themselves, they did have arguably a significant benefit from chemotherapy, where about a quarter of them had their cancer shrink, and median survival is right at that 10 to 12 month range. There was no difference in the 4 arms, and that's why we can use carboplatin and paclitaxel. while the response rate might be a touch lower, there is really no major difference in survival. Still, when we're looking at 2-year survival, you're seeing that only 10 to 11% of people are alive, which is very low. I don't think many people other than chemotherapists would consider this successful, right? But nevertheless, so with chemotherapy-based backgrounds, you're going to shrink the cancer about 1 out of 5 times. You're going to keep people alive on average for 10 to 12 months, and you can only treat people who are in good shape when they come to you. And that's really the background of where we are with non-small cell lung cancer, where the story starts. And the story was actually paused there for about 15 years without any major significant changes. And this is where I get my less than 5% 4-year survival. And this is just the Kaplan-Meier survival curve. You can see that there is no tangible difference. These are the 4 different chemotherapy arms. This is, again, percent alive over time. You can see how the curves all go down. Over half of people are dying by a year, and there's no demonstrable difference between those curves. They all look essentially the same. Therefore, it is appropriate to use carboplatin and paclitaxel. The next quote-unquote step forward was adding bevacizumab to carbotax. This was the ECOG 4599 study, which randomized people to either carboplatin and paclitaxel with metastatic adenocarcinoma of the lung. Remember, you cannot use bevacizumab in squamous cell carcinoma of the lung because it causes fatal hemoptysis in some people, which you don't want to obviously do. But this randomized people between the bevacizumab containing arm versus just the chemo alone. Again, it was a very large study. Everyone had a good performance status, as you can see by the big fat blue arrow. And also about half of people only had one site of disease, which is kind of against the caveats that I gave in the beginning, but points out this was a very favorable patient population. Almost half of these people had a single site of metastases. Currently, we would go after that with modalities such as stereotactic radiation, surgical resection, radiofrequency ablation, or something of that nature. So this is a very good patient population. So when you look at it, these are the Kaplan-Meier survival curves. It shows that you improve survival and progression-free survival by adding bevacizumab to the carbotaxol backbone. This benefit is very modest, as you can see. The hazard ratio is only about 0.8, so you have about a 20% improvement. And the other thing to note is here at the tail of the curve, everyone is still dying. You're not saving anyone's life. You're prolonging life by a couple of months, but it's not like you're giving this therapy to people and now they're cured and they go on to live a normal, happy, healthy life. The downside of this, or the dark side of this paper, is on this slide, which is actually very interesting. And the reason why, at least I do not actually write for bevacizumab almost ever in non-small cell lung cancer in the United States. And it's based on this slide right here. And the reason is when you look at the combination of carbotax bev versus carbotax, you have in the carbotax arm, or just the straight up chemotherapy arm, you have 10% of people dying from something other than cancer and 90% of people dying from cancer. When you add in the bevacizumab, you have 85% of people dying from cancer, 10% of people dying from something other than cancer, but you have 5% of people dying from the bevacizumab, either from a arterial or venous thromboembolic event, or a perforation, a wound dehiscence, something else awful, which then led to their death. So by adding the bevacizumab, that's why you don't actually change the survival curves over time. That's why with the bevacizumab arm, the tail does not go up on the Kaplan-Meier curves because there's actually fatal side effects from the bevacizumab, which balance out that extra 2-month average overall survival you get, and doesn't really change dramatically the overall outcome for these patients. But nevertheless, this was seen as, at the time, as a major advance because it was one of the first trials after probably 14 to 15 negative randomized phase 3 trials to actually show any improvement in overall survival, even though it was only a 2-month improvement in overall survival. So where do we go from there? All of these things, chemotherapy, bevacizumab, are non-targeted therapies. They are therapies that are really blanketed, right? The only way that they're quote unquote targeted is you can't use Bev in squamous cell due to fatal side effects. You can't use pemetrexed in squamous cell because it does not work. But otherwise, it's really just treating everyone the same. Everyone gets the same therapy. So how do we actually figure out how to treat people better? So this is a pie chart looking at the frequency of mutations in all comers with adenocarcinoma of the lung. And as you can see, even though these cancers may look identical underneath the microscope, they are actually genetically extremely different. And you can interrogate the cancer cells by methods such as Foundation 1 and other things which are available, though expensive, but they are available. And I would argue that actually figuring these things out is more of a benefit than giving someone bevacizumab, which is also extremely expensive. And again, remember, there was no change on that survival curve I showed you. Rather, no change on the tail, and only a modest improvement in survival. But these abnormalities and figuring these out can actually really change outcomes. And I hope to show you that as we talk about the evolution of lung cancer. This is a graph then showing people who are non-smokers and showing that you can find driver mutations in a even larger percentage of people who are non-smokers. So non-smokers are about 40% of lung cancer cases in the United States. But they, again, just emphasizing that it is incredibly important to profile people because these cancers, even though they look identical, are actually very, very heterogeneous genetically. So as I sit here in 2021, what is essential for treating lung cancer in the United States is this panel of testing. This is what we would want to know on every single patient. Again, you can get these tests for through Foundation Medicine, which I know you guys have access to other than the financial barriers, but I saw the reports when I was there, so I know you can get them. But this is how we move the bar off of carbotaxol and bevacizumab. This is how we beat that 12.2-month survival. So we're going to start off by talking about the driver mutations, and then we'll talk about immunotherapy. One thing to know is that you have to actually test for everything. You don't just test for one thing. Don't just send a PCR unless there's a financial reason, obviously, that you have to only send a PCR, because people can have more than one mutations, and that's what this figure shows. You can actually have people with coexisting mutations. People can have both a EGFR and a ALK rearrangement. Though it's uncommon, people can have multiple mutations. So don't just send one test. Just don't send a PCR. Don't just send a FISH. Do the comprehensive profiling so you actually know everything you can possibly treat, everything you can possibly offer the patient, right? Because your job as an oncologist or a chemotherapist is to offer people as many options as possible to prolong life and to move that 1% 4-year survival. Okay. So when we talk about using driver mutation therapy, we often talk about using tyrosine kinase inhibitors, not exclusively tyrosine kinase inhibitors, as I'll show you later, but this is really where the story started. And tyrosine kinase inhibitors are ATP mimetics, which means that they compete with ATP on the intercellular surface with the tyrosine kinases, and they look to disable them. Okay, so they outcompete ATP to interrupt signaling. The important thing to know there is they're not actually killing the cancer cells, and there's a debate about whether or not you can ever cure somebody with a tyrosine kinase inhibitor because it's not tumoricidal. You're just basically outcompeting ATP, shutting down signaling and making the cancer go to sleep, so to say. So looking at EGFR mutated lung cancer, this is really, again, where the story started. And it was also, as you can see, the biggest part on the pie graphs, because it is the most common in non-smokers. So this is looking at a randomized trial. This is randomizing people who have EGFR mutation positive disease to gefitinib, which is a first generation EGFR tyrosine kinase inhibitor, versus Carbotax. So things that should out to you a little bit right here. It improved outcomes for progression-free survival by 50% based on the hazard ratio. Remember that for bevacizumab, it was 0.7. So the addition. So clearly there's a significant improvement by adding gefitinib, or by gefitinib over chemotherapy. And you can also see that the Kaplan-Meier graph is significantly improved, though again, most people are not making it to 2 years, but there's definitely an improvement in progression-free survival by gefitinib over conventional chemotherapy. Also, gefitinib is significantly better tolerated than chemotherapy, this is what it's showing. So this was really one of the first major steps forward in targeting cancer, or targeting non-small cell lung cancer. Each of these graphs in the dark blue bar shows how gefitinib is better tolerated than chemotherapy. But again, remember, it also improves outcomes. So by giving someone a pill a day for an EGFR mutated lung cancer, you can make them live longer with better quality of life than you can when you give them chemotherapy. Significantly better. And this has really been shown across multiple studies. This is looking at a meta-analysis looking at either gefitinib or erlotinib versus chemotherapy for EGFR mutated lung cancer, showing a significant improvement for basically any EGFR TKI, first generation versus chemotherapy alone. You can obviously see this by the move of the Kaplan-Meier curve over to the right. But again, when we're getting out to 4 years, there's vanishingly few people alive with first generation. So we're not really to that target that I set at the beginning of the lecture of wanting to get 4 and 5 year survivals up over that 1%. But here on the forest plot, you can see that in no study did chemotherapy outperform the TKI in someone who has a mutation. The thing I was saying, people who do not have mutations, these drugs are largely worthless. I know that erlotinib was originally shown to be efficacious as third-line therapy in a non-selected patient population, but the magnitude of benefit in that study was extremely small and was probably driven by people who had EGFR mutations. So really, you can't just give these drugs to someone because they're a non-smoker and they have an adenocarcinoma. You really do have to profile everybody and make sure that you are giving the right person the right drug, and then you can significantly improve outcomes. There are there's actually 3 different mutations in EGFR. This is just showing that regardless of whether it is a exon 19 deletion or an exon 21 mutation, you still improve outcomes with these tyrosine kinase inhibitors over chemotherapy. Notably, the exon 20 mutations are not sensitive to these drugs. So again, that's why I'm saying that you need the comprehensive profiling. If somehow you just got back a report just generically saying, oh, there was an EGFR mutation, that still is not enough information. You actually need to know exactly which mutation it is, because 19 and 21 are sensitive to these drugs versus 20 is not. And people who have no mutation, chemotherapy would actually outperform the tyrosine kinase inhibitor dramatically. So where do we go from here? So this is now looking at osimertinib in EGFR mutated non-small cell lung cancer. And this is currently the standard of care in the US for these patients. These are waterfall plots. So the top one is osimertinib. Every line going up is a progressive disease event over the line of 0. Every arrow going down is a cancer shrinking. Every individual bar represents a patient. As you can see, the vast majority of people who are treated with osimertinib for EGFR mutated advanced non-small cell lung cancer have a significant improvement. Keep in mind that with chemotherapy, remember that response rate with carbotaxol was 17%. So that'd be way down here, and that's it. Okay. And with chemo and with bevacizumab added, it only gets it up to 30%, as opposed to this, where you're seeing about 90% of people will have tumor shrinkage when they're treated with the appropriate drug for the appropriate disease. Okay, and this is just, again, emphasizing that, because remember this table from Judith Schiller's paper from 2000, where she was randomizing the 4 different platinum-based chemotherapies, showing that they only had response rates of that 19%. And look how many people are responding when you're actually treating with a tyrosine kinase inhibitor for a molecular profiled patient. That's, I would really argue, is saying that it is worth the money to profile people and treat them appropriately, because you don't get outcomes like this with bevacizumab. This is, again, looking at it, this is osimertinib versus either erlotinib or gefitinib in this study. And you can see that it significantly improves progression-free survival. It protects against brain metastases, and it improves overall survival in patients to start with osimertinib. So also now, when you're starting with osimertinib, you're noticing that we're getting our 24-month overall survival up for the first time. Okay, so there are a group of patients that are going to start doing very well for a long time with these drugs, but still, at 2 years, only 25% of people are still on drug with osimertinib who have brain mets. And for progression-free survival, overall, it's about 40% of people are still on therapy at 2 years. Not where we want to be, but dramatically better than chemotherapy. Because remember, when we were looking at these graphs with chemotherapy, almost everyone was dead by here, right? And instead, and here's overall survival, almost everyone was dead in this 12 to 14 month range, versus when you're targeting, this is 80% of people still alive. This is now showing that these drugs or osimertinib crosses the blood-brain barrier, which is a beautiful thing. So I've actually been able to not use whole brain radiation therapy or any other kind of radiation therapy in people who have EGFR mutated non-small cell lung cancers with brain metastases. Instead of sending them for chemotherapy and whole brain radiation therapy, you just put them on osimertinib alone. It will cross the blood-brain barrier and control the cancer for the majority of people. This is now looking at 3-year update for overall survival for this population. Again, osimertinib versus erlotinib or gefitinib. And though you're not really supposed to do cross-trial comparisons, this is me comparing it to platinum-based chemotherapy at 30 months. So when you look at the line, almost everyone is dead versus, what is that, 65, 70% of people are alive at 30 months. Again, trying to emphasize the point that by appropriately medically testing, you can dramatically change outcomes and make people live dramatically longer. Again, this is then those same things just numerically showing overall survival at 36 months at 50%. So we're actually now starting to get up off of that 1 to 2% of people with chemotherapy or bevacizumab who would be alive. Now, this is not a story that's completely unique to EGFR, though. So we're going to talk about the other ones in a minute, but also keep in mind all of these people are destined to fail. Having a quote-unquote permanent or long-term response to even osimertinib, everyone's going to fail eventually. So people are not going to respond forever. So even if their scans go to normal, you cannot tell anyone that they are cured. Even if you have these graphs showing that a lot of people are alive years out, you cannot say that they are cured. So everyone's going to become resistant. It's very important to reprofile people at resistance. We will actually rebiopsy and repeat all of our genomic profiling looking for resistance mechanisms. We're looking for things that we can target. People can actually pick up things like EGFR amplifications, BRAF mutations, MET amplifications, and other things that we can potentially target. So it is important to rebiopsy at progression and reprofile, again, acknowledging the financial toxicity of that. This is a way to actually start trying to figure out if there's another option before just moving to platinum-based chemo. Because as I've shown you, targeted therapy with EGFR is dramatically better than chemotherapy. So this is the next step, probably. This is patritumab deruxtecan. This is a anti-HER3 monoclonal antibody that's conjugated to deruxtecan, which is an irinotecan relative. And this is looking at treating people who have metastatic EGFR mutated adenocarcinoma of the lung who failed osimertinib, failed chemotherapy. This was a study that was just presented in 2001 using this conjugated monoclonal antibody. This was a phase 1 study. People got this monoclonal antibody by vein over an hour, once every 21 days. These patients had a good performance status. Again, even in 2021, we were still only taking performance status 0 to 1, as I had pointed out in the beginning. About half of them had brain mets, and they had about 4 lines of therapy. So this was a heavily pretreated patient population. Everyone had had a TKI. Almost 90% of them had osimertinib. 90% of people had chemotherapy beforehand. So people had multiple lines of therapy before they received this drug. When we used this drug, our response rate was right around 1 out of 5, but the majority of people actually did get tumor shrinkage. So you were able to control the disease for about 70% of people, and those durations of responses lasted about 7 to 8 months. So not fantastic, but way better than chemotherapy in this situation. And this is the waterfall plot, again, showing this, where the majority of people had tumor shrinkage, because this line right here through the middle of 0, anything up again is cancer growing, anything down is cancer shrinking. So this is showing some hope for metastatic non-small cell lung cancer, that you have something to offer them other than necessarily giving them chemotherapy. This drug was also extremely well tolerated, as you can see here, with only 10% of people requiring dose discontinuations. So again, way better than chemotherapy as tolerance. Only 1 out of 5 persons actually had to have a dose reduction. Okay, so this gives us a potential option for people who have failed EGFR targeted therapies by using this new monoclonal antibody conjugate. Now, I remember I had said that EGFR mutations 19 and 21 were the ones that were sensitive. What about exon 20? Well, most recently, there's been a new study using a MET EGFR bispecific antibody. This is, again, showing waterfall plots. This is actually FDA approved, so this is something that we can use, where you can see that, again, the vast majority of people are having tumor shrinkage. Even if they have had previous chemotherapy, they have a vast majority having tumor shrinkage. Keep in mind that second-line chemotherapy for non-small cell lung cancer with docetaxel or pemetrexed only has a response rate of about 8 to 10%, versus looking at this graph, you can clearly see with this bispecific antibody for people with EGFR mutations, the majority of them are responding, and they're responding for right around a year, which actually sounds very reminiscent of the initial studies that I showed you using gefitinib and erlotinib. So this is just the first step in the exon 20 story, but we at least have something to target it. So now we have drugs to target all 3 known EGFR mutations, and we actually have a drug for potentially targeting people who have failed EGFR-directed TKI-based therapy with the deruxtecan monoclonal antibody drug conjugate. So we're developing options away from chemotherapy, all of which are dramatically better than chemotherapy. Looking at a couple other examples, this is now ALK rearranged lung cancer. This is a much smaller piece of the pie, but still a significant piece of the pie. This is looking at crizotinib in its first study for showing responses for ALK rearranged non-small cell lung cancer. Again, these are my favorite waterfall plots. As you can see, the vast majority of people who received crizotinib who had an ALK rearrangement responded. And here's just showing CT scans before and after with near complete clearance of the disease, which is obviously extremely impressive because, again, remember, only 20% of people respond to chemo, and when you're using a drug like crizotinib, it's about 80% of people are going to have disease shrinkage. The durability is right around 10 months, as you can see here and on the swimmer's plot. These are not responses that last forever. But again, this is very similar because crizotinib was the first drug for treating ALK rearranged lung cancer. This data is almost identical to the bispecific antibody I showed you for exon 20, and again for first line with erlotinib or gefitinib, where with these drugs hitting their target, they'll get a response for about 80% of people, and that response will last right around 10 to 12 months. Again, putting that in context, remember, this is a response from the first thing you did lasting nearly a year, versus with chemotherapy, everyone's dead at almost a year. So even after these drugs, you could potentially give someone chemo. But just like osimertinib improved on erlotinib and gefitinib, the question comes, can we improve on crizotinib? So this is looking at updated overall survival from the ALEX study. This is looking at people, now we're starting to get out to this 4 to 5 year mark that we've been interested in, where you randomize people on the blue line to crizotinib versus on the red line to alectinib. This is looking at progression-free survival. The average progression-free survival with alectinib was almost 3 years. So that's a huge jump forward off of the crizotinib, where the average progression-free survival, like I said, is right at that 10 months, which is very typical for a first-generation targeted therapy. But again, that progression-free survival is equaling the overall survival you get with chemotherapy. So these people are living a dramatically longer time and having much longer and more durable responses. This is looking also at alectinib is able to prevent brain metastases, because just like osimertinib, alectinib, i.e. the second generation tyrosine kinase inhibitor, actually crosses the blood-brain barrier and protects the brain from metastases. Again, this is just showing that in a graphic form, showing that alectinib prevents brain mets, just like I showed you that osimertinib prevents brain mets. So again, the second generation of these drugs is showing dramatic improvements. And now here's the overall survival from the ALEX study updated at year 5. And remember this slide that I started with from 2004, showing less than 1% of people receiving chemotherapy in a non-selected patient population being alive at 5 years with just chemo alone. People who were randomized to the alectinib arm in that ALEX study with a 5-year update, 63% of people were still alive. That should be a very powerful statement. So by profiling a patient appropriately and giving them the appropriate targeted drug, you can change their chance of being alive at 5 years from less than 1% to 63%. That is worth the cost of figuring things out. That is worth the cost of profiling these patients. That is a dramatic difference. That is not something that bevacizumab can give you. That is not something that PET scans can give you, which is another very expensive thing that is frequently used. By doing the actual profiling, you can get amazing outcomes for the appropriate patient populations. So now just to continue with that, this is not only exclusive to EGFR and ALK. So this is looking at ROS1 mutations. Again, a tiny piece of the pie at just 2%. But with crizotinib, you again get that response rate of 70%. This is looking at the waterfall plots, right? Where you can see dramatic outcomes with only, 2-3 people out of the 51 not having tumor shrinkage. So 48 out of 51 patients are having tumor shrinkage, which is incredibly impressive because remember, only 20% of people will have tumor shrinkage with chemotherapy. So obviously, by finding the ROS1, even if it's only 2% of the patient population, if you find the correct part of the patient population, you can make dramatic improvements in outcomes. Same is true about BRAF mutations, where again, we're looking at that 60%. And this is looking at it first or second line, again, with my waterfall plots, which I love so much. You can see the vast majority of people are responding to these drugs, and they're responding for to this therapy, even as a first-line therapy, they're responding to it for just about as long as someone would live if you treated them with chemo alone, meaning these people are going to live much longer because after they fail dabrafenib and trametinib for their BRAF mutation, then you're going to give them chemo, then you're going to do other things. And you can there's no cross-resistance between these tyrosine kinase inhibitors and there's no cross-resistance between the tyrosine kinase inhibitors and chemotherapy. So you can obviously expect to have good outcomes or chemotherapy outcomes after they fail their tyrosine kinase inhibitors. But there's even more things coming out. So then another piece of that pie or that puzzle was looking at HER2 mutated non-small cell lung cancer. So this is a study of 39 people who had failed chemotherapy with metastatic non-small cell lung cancer, who have a HER2 mutation. Again, remember, small piece of the pie, maybe 2%. But when they are treated with this drug, which is trastuzumab, which you should all be familiar with, then conjugated with a monoclonal, that monoclonal antibody is conjugated with deruxtecan, which again is that irinotecan conjugate, and is treated, you can see the vast majority of people are responding. In fact, all but one patient, 38 out of 39 people's cancers shrank with this, which again, by finding and defining that small piece of the pie, you can dramatically improve outcomes. Most recently, they have actually started targeting KRAS. This drug was just approved with sotorasib. Okay, so we now have a KRAS inhibitor as well, and especially in smokers, that's a huge piece of the pie. Okay, but you can also see as I've gone through, we've talked about EGFR, ALK, HER2, BRAF, ROS. These are all targetable, even if it's a small piece of the pie. If you find the appropriate piece of the pie and put the person in it and give them the appropriate drug, they will have dramatically better outcomes. So this is looking at sotorasib, showing again with my waterfall plots that the majority of people are responding. Okay, and this is looking at people with non-small cell lung cancer, and right around 2/3 of people are having some degree of tumor shrinkage. And these are people who have failed chemotherapy. So again, putting in context that with chemotherapy alone, you would only be expecting to have an 8 to 10% response rate for second-line therapy. You would not expect 2/3 of people to be getting better. And these responses are lasting right around that 6 to 7 month. So it's a little bit inferior to the other first-generation inhibitors, but actually finding something that inhibits KRAS has been a big step forward. Obviously, as you can expect now, there will be future generations of these drugs which will come out, which will show even better outcomes, just like you saw the changes between crizotinib and alectinib, and the changes from erlotinib to osimertinib. Sotorasib's next generation will do better than this, but once you figured out how to target that specific mutation, you can see how you can improve outcomes. So this is, again, looking at the CodeBreak 2 study, because what I had first showed you was just the phase 1 data with the targeting KRAS G12C, but also keep in mind, it's KRAS G12C. Your report actually has to tell you what mutation you have. There are other KRAS mutations. You need to know exactly what you are targeting, because if you give this to a different KRAS mutation, it will do absolutely nothing. Okay, looking at this study, this was 162 patients. Again, everyone had been pre-treated, so if you were using chemotherapy, you would expect people to have very low response rates, i.e. order of 8 to 10%. And again, these people are pre-treated. Up to a quarter of them have had 3 different chemotherapies. Again, with KRAS mutations, the majority of them are smokers, which is nice because most of the other mutations other than BRAF that we've discussed are typically in non-smokers. Looking at this, they got an objective response rate of 37% and controlled the disease for 80% of people and got in this study right to that 10 to 12 month duration of response that you see with the first generation erlotinib and gefitinib and crizotinib. And again, you actually had 3% of people having a complete response, which is getting kind of close to the 8% of people who'd had any response to docetaxel. Progression-free survival, again, right around that 7 months, but your duration of response is 10 months, which is very analogous for first generation inhibitors. And overall survival in the second setting is 12 and a half months, which should be impressive to you. Because again, this is not first line. So this is somebody, a quarter of these people have had 3 previous treatments, and you're still getting an overall survival better than you would get with chemotherapy plus bevacizumab in the first line. So again, showing that this is an interesting drug. One other thing to point out that this is not tissue agnostic though. So with the exact same mutation in colorectal cancer, almost no one responded, okay? So that is different than mutations such as NTRK or other things such as that, which are tissue agnostic. This really is only for the exact mutation in these in non-small cell lung cancer. So what do you do for people who do not have a driver mutation? Because remember from those pie graphs, even though I've been showing the great outcomes from the small slices of the pie, the majority of the pie doesn't have a driver mutation. So that's where we need to define things like PDL1, total mutational load, and DNA mismatch repair status. This will help tell us how we can actually use immunotherapy and how we can effectively target the other half of the pie. Through the following slides, it will show that, again, just like when we have found a target, we can dramatically improve outcomes over chemotherapy or chemotherapy with bevacizumab. When we can target the appropriate patient with immunotherapy, we can dramatically, again, improve outcomes. Unfortunately, I guess I've been long-winded and I've already gone for 52 minutes or so, and I have to go to clinic. If you guys are interested, I can join you again at a later date to go through immunotherapy non-small cell lung cancer. I'm on slide 62 out of 116, so I'm just over halfway through. So the next half will be smaller, but there's no way I can appropriately get through it in just 10 minutes. I apologize for that. So I will wrap it up there and thank Alisher for the invitation and then open to any questions.
Yeah, it was one question from the floor, and it was, how do you manage with the metastasis to the bone when it is lung cancer? So one.
It doesn't matter.
Ah, okay.
So, I mean, if you're asking about, do we use denosumab or zoledronic acid? We do for anyone with bone metastases who's seen a dentist, but those are not really changing survival, right? Those are decreasing skeletal related events. They're not changing survival. So if I was in a resource limited situation where I could only choose to spend so much money, rather than putting someone on denosumab or zoledronic acid, I would spend that money on profiling them so I could get them a better therapy.
Okay, can I translate the answer?
Sure.
Был вопрос из аудитории. Как они лечат метастатический рак в кости при раке легкого? И ответ звучал так, то, что они тоже используют деносумаб и залендроновую кислоту, но они больше делают упор на применение таргетных препаратов, так как они улучшают выживаемость пациентов, в то время как препараты залиндроновой кислоты, они только укрепляют кости, но никак не влияют на продолжительность жизни пациентов. Okay. And only about 60% of people have some mutations. Am I right?
Yeah, depending on smoking status, it's between 40 and 60%. And the other people then you would use checkpoint inhibitors in. But again, I ran out of time. Almost no one in the US is going to get chemo alone. In fact, I don't know any non-small cell lung cancer patient that you would treat with chemotherapy alone. Everyone's going to get either a targeted drug, which again, depending on smoking status, is going to be between 40 and 60% of patients, or some type of checkpoint inhibitor combination. The days of Carbotax or Carbotax Bev are gone. We only use those drugs in second, third, fourth line when we've run out of everything else new. Because with those drugs, your outcomes are extremely limited. I mean, people are only lasting 12 months. And as I showed you, by appropriately targeting things, you can have 60% of people alive at 5 years. So our outcomes are incredibly good.
So may I translate it also?
Yes.
For the audience? И мой вопрос звучал так, то что какой процент пациентов обладает генетическими мутациями? Он сказал, около 40-60% пациентов немелкоклеточным раком легкого имеют определенные мутации, но практически все пациенты в Соединенных Штатах Америки получают препараты таргетной терапии и иммунотерапии, так как применение данного вида таргетной или иммунотерапии позволяет добиться 5-летней выживаемости до 60%, в то время как вы видели один из первых слайдов, то, что использование только химиотерапии имеет ограниченные результаты и всего лишь составляет 1%. Поэтому практически все пациенты в США получают таргетную терапию или иммунотерапию. Okay. If you are hurry, we can continue next time. You should only say the date, and I think we can organize the continue of your lecture.
Perfect. Sorry about that. But just to do it justice, I guess it took me 50, 60 minutes. So sorry. But it's important to go through the data and to understand, because again, well, the bone question, PET scans, all of those things cost a ton of money in a resort, because there's no health insurance in Uzbekistan. So the patients and their families are paying for all these individual things. If I was choosing what I was paying for, I would not be paying for Zometa. I would not be paying for bevacizumab. I would not be paying for PET scans. I would be doing CT scans and genomic profiling, because that's where you actually move the bar and change survival.
May I translate it the same? Because I think it's very good words.
Yeah.
Ну, мнение профессора Мартина заключалось в том, что я бы не тратил бы деньги на замету, я бы не тратил бы деньги на проведение ПЭТ-сканирования, я бы не тратил деньги на применение бевацизумаба у этой категории пациентов. Я бы, в свою очередь, использовал бы обычную компьютерную томографию и генетическое профилирование, то есть определение генетической мутации и в последующем применение таргетных препаратов, которые позволяют получить очень хороший результат лечения. Okay.
Thank you very much for the opportunity.
Okay, thank you so much for your time, and I hope we will see each other in the nearest future.
Yes, and I'll get you a date to go through the second half of the data.
Okay, thank you. Okay, see you next time. Bye-bye.
Bye.